So we'll be seeing few topics from pediatric orthopedics now. Okay, the first thing what we have been seeing is CDH, which is also called as congenital dislocation of hip. Congenital dislocation of hip. Okay, so congenital dislocation of hip means when the child is born, the patient is presenting with a dislocated hip. Okay, this is also called as developmental dysplasia of hip. This is also called as developmental dysplasia of hip. This is also called as developmental dysplasia of hip. This is commonly seen in child who are born by breech presentation, and that too with an extended knee. When a child is delivered, normally child delivered part of the first part comes out, not head. Okay. The opposite, that is called a cervical presentation. That is called as cervical or cephalic presentation. That is called as cephalic presentation. Head comes out as cephalic presentation. Opposite to that is if the buttock region comes out, that is called as breech presentation. So if a child is born with a breech presentation with an extended knee, they have got more chance for CDH. They have got more chance for CDH. In certain cultures, especially in American side, once a child is born, they rotate, they roll the child in a towel like this. These are called swaddles. These are called as swaddles. So in swaddlers, CDH is common. In swaddlers, CDH is common. So it also depends upon the culture also. Okay. So whenever in a child, whenever you keep the hip adducted, there is more chance for it to get dislocated. So if you keep the child hip adducted, there is more chance for it to get dislocated. So that is why in swaddlers, CDH is common. That is why in swaddlers, CDH is common. It is not common in our side. Why it is not common in our side? Once a child is born, how the mother carries the child? How the mother carries the child? Once it borns and grows, he carries in the hip region. Once a child sits in the hip region of the mother, how the hip is adducted or abducted? எப்படியா குழந்தைய தூக்கி போறாங்க அப்பா அம்மா அதெல்லாம் கூட பார்த்ததே இல்லையா யாரும் in they keep the child by the side so the hip gets abducted. Once hip abducts, it won't dislocate. When you keep it adducted, it dislocates inside. So it is not common in our side. In America only it is common. They are not carry the child like that. Okay, so CDH is common there. Now how are you going to diagnose congenital dislocation of hip? You do two tests to diagnose. One is called as Barlow's test. Another one is called as ortholony test. Another is called as ortholony test. Barlow's test is if you try to dislocate the hip by doing adduction, then it is called as Barlow's test. So you try to dislocate the hip. Okay, and if you try to reduce the hip, you hear a click sound, then that is called as ortholony test. So in Barlow's test, you dislocate the hip. When you try to dislocate, it dislocates. So which is a test to diagnose Barlow, which is a test to diagnose CDH. In ortholony test, the dislocated hip is reduced back into the hip. So you hear a click sound, that is called as ortholony test. So these two tests are very important in diagnosing CDH. Barlow's test and ortholony test. Repeatedly asked question again. Most commonly asked question in this area. Okay. Now you can also diagnose this condition by taking this investigation called as ultrasonogram. Because in young child, the head will not be visible in an X-ray. குழந்தையில head வந்து தெரியாது X-ray because in child the head is cartilaginous. In newborn, the head will be cartilaginous. Cartilage cannot be seen in an X-ray. So X-rays are not useful in newborn to diagnose CDH. Instead of that, you are using ultrasonogram to diagnose that condition. You measure two angles in that, alpha angle and beta angle, to diagnose CDH. So using ultrasonogram, you can diagnose CDH by measuring these two angles. By measuring these two angles. Now, once you diagnose the child with CDH, how are you going to treat the child who has got CDH, congenital dislocation of hip? How are you going to treat it? If the child is between age 0 to 6 months, if the child has got age between 0 to 6 months, you can apply a harness called as Pavlik harness. You can apply a harness called as Pavlik harness. You can have a harness called as Pavlik harness. Okay, so the Pavlik harness is like this. The Pavlik harness is like this. The child will be put in a belt and see how the hip is kept. It is kept adducted or it is abducted. Abducted. So this is how the child hip is kept. So this is called as Pavlik harness. If the child is more than 6 months of age, so 6 months up to 2 years, you can treat this condition with a spica called as hip spica cast. Hip spica cast. So 6 months to 2 years, you can treat it with hip spica cast. From 3 years, you can do osteotomy on the femoral side, which is called as derotation osteotomy. It is called as derotation osteotomy. If the child is much more older, then you can do pelvic osteotomy. Pelvic osteotomy. Example is Salter's osteotomy. Salter's osteotomy or Pemberton's osteotomy. Or Pemberton's osteotomy. Okay. So these are the various methods to treat congenital dislocation of hip. Okay. So the pathology is very simple. The hip dislocates in child. When the hip dislocates in a child, newborn child, we call that as congenital dislocation of hip. And it is common in children who are delivered by breech presentation. Okay, it is diagnosed by two clinical tests. The name of the clinical test is very, very important. Barlow's test and Ortho test. In Barlow's test, Hindi la Bagarna theriyuma? Anybody knows Hindi theriyumla inga ellarkum? No, no one knows Hindi. Bagarna enappa? Odradha. Bagarna velila kediyada. I think Bagarna velila nenikkren. Bahara. Okay. Bagarna velilaya. So Barlow Bagarna vechukkom. So you dislocate the hip. So hip on the velila pogudhu. So Barlow's test is dislocation of hip. You reduce the hip, then the test is called as ortholonist test. Then the test is called as ortholonist test. These two tests are repeatedly asked questions. That is why I am insisting on this. And how you manage the child? If he is below 6 months of age, you treat it with Pavlik harness. If he is between 6 months to 2 years, you apply hip spica cast. By 3 years, you can do surgeries around the femur side or around the pelvic side. So it is called as derotation osteotomy and pelvic osteotomies respectively. Okay, clear? So this is about the management. See, there are one more clinical test to diagnose congenital dislocation of hip. Just imagine, yesterday we saw posterior dislocation. So whenever the hip dislocates, what happens to that side of the limb? It will be of same as the other side, or it will be shortened. It will be shortened. So that shortening can be clinically tested by a test called as Alice test. So this is how they do Alice test. You can see when they keep both the knees flexed and if they keep it side by side, one knee is at a higher level, other knee is at a lower level. So the knee which is at a lower level is the where the shortening has happened. So this can be used to test or used to diagnose CDH. It is called as Alice test. This test is called as Alice test. Okay. So in Alice test, you can diagnose CDH. There is also another test called as telescopy test. Telescoping test. So telescopy test can also be used to diagnose CDH. Alice test can be used to diagnose CDH. Barlow's test and ortholonic test can be used. Okay, clear? So this is about congenital dislocation of hip. So next pediatric condition which is commonly seen around the hip is SCFE. What is, yesterday we saw this? Okay. So SCFE stands for slipped capital femoral epiphysis. Slipped capital femoral epiphysis. Okay. So in order to understand this condition, we'll just draw a diagram here. Greater trochanter, neck of the femur, and the head of the femur is here. Okay. And there is a zone here called as the epiphyseal cartilage. What is this cartilage called as? Epiphyseal cartilage. Once epiphyseal cartilage is there, the bone will increase in length. The bone grows. Now, we will take this epiphyseal cartilage out and we will expand the epiphyseal cartilage. When we expand the epiphyseal cartilage, we will be seeing 4 zones in it. We will be seeing 4 zones in it. So, okay, I am just taking the epiphyseal cartilage out. This is the epiphyseal side. This side. This is the epiphyseal side, and this side is the metaphyseal side. This is the metaphyseal side. So we are taking out the epiphyseal cartilage and we are expanding it to see what is happening inside. And when I expand it, I see 4 zones in epiphyseal cartilage. Okay. The first zone is called as zone 1, also called as zone of germinal cells or resting cells. Okay, they keep quiet. At times they will multiply and give new cells. So that is the zone. That is the importance of the zone. So cells in the zone will multiply and produces new cells that goes to the next zone called as proliferative zone. Proliferative zone. This is called as proliferative zone. And from the proliferative zone, cells goes to the next zone where they increase in size. So this is called as hypertrophic zone. This is called as hypertrophic zone. From the hypertrophic zone, it goes to the next zone called as zone of calcification. Zone of calcification. That is the zone 4. So you have got 4 zones in a cartilage. Normally when the epiphyseal cartilage is there, cells from germinal epithelium multiplies to form the proliferative zone. Cells from the proliferative zone increases in size, becomes the hypertrophic zone. Cells in the hypertrophic zone calcifies and forms the bone. That is how the bone grows. So cells from one zone to other zone goes and they keep growing. Okay. Now when these zones are active, the weakest zone of this is hypertrophic zone. In the zone, the weakest zone. Cells ku nadula attachments romba kammiya irukku. So the attachments between the cell is very, very weak. That is why hypertrophic zone is the weakest zone. And whenever the patient has got an increased growth hormone, the hypertrophic zone increases in size. When hypertrophic zone increases in size, it becomes more weaker. It becomes more weaker. Okay. So can anyone tell me when the growth hormone increases in our body normally? Normally, growth hormone increases during adolescent period. During puberty, the growth hormone is produced more in our body so that you grow more. Your height the adolescent period height so during that period, growth hormone increases, hypertrophic zone increases, and it becomes weaker. If the child is more obese, so more load is transmitted across the hip joint, the weaker zone can get fractured and it slips. So this is called as slipped capital, means head of the femoral epiphysis. Okay. Simple. So hypertrophic zone becomes weaker around the adolescent period, and if the patient is overweight, the slippage of head of the femur occurs, that is called a slipped capital femoral epiphysis. So this is common in adolescent age group. This is common in adolescent age group where the growth spurt is more. It is also common in males. It is also common in obese males. It is also common in people who have got imbalance between growth hormone and sex hormone production. So that means if they have got endocrinopathies, the imbalance between growth hormone and sex hormone can cause SCFE. Once if the dislocation happens like this, there will be restricted abduction. And internal rotation. Abduction and internal rotation are restricted in this. So the hip will have reduced abduction and reduced internal rotation if this condition happens. Now normally when you take an X-ray of the hip, okay, so this is the neck region, this is the head region, this is the greater trochanter region. If you draw a line through the superior aspect of the neck, it cuts the head of the femur like this. This line is called as Klein's line. If the head has got SCFE, that is if it has slipped out, so the head has got slipped like this. Now if you draw a line, does it cut the head or it does not cut the head? Once the head has slipped down, it is not cutting the head. This sign is called as Strithoven's sign. So Strithoven's sign is seen in SCFE. It is diagnostic of SCFE. Okay. So you draw a line called as Klein's line. If it is not touching the head or if it is not cutting the head on its lateral part, then that sign is called as Strithoven's sign. Okay. Hey, after this, I'll tell you one more sign in CDH. We just left that. I'll tell you one more sign. Okay. So how are you going to treat this condition? So once the head has got slipped out, you have to reduce the head and you have to fix it with a pin. So you have to reduce the head. Back like this, and you put screws to fix it. So pinning or screw fixation is the treatment of choice. This condition can occur bilaterally. This condition can occur. So the opposite side, even if it is not slipping, prophylactic pinning can be done. On the opposite side. Even if it is normal, to prevent slippage, you can do prophylactic pinning. Okay, so this is about a SCFE. So in SCFE, please remember all these points. Strithoven sign is important. Again, a frequently asked question. One sign which we left in here is, see, yesterday we saw posterior dislocation of hip in adults. When posterior dislocation of hip happens, which is the artery we cannot palpate? What artery you cannot palpate? Femoral artery pulsation can, because yesterday I told you, if you want to feel for an artery, against you have to compress it against a bone. Radial artery, if you want to feel, you have to compress against radius. If you want to feel the femoral artery, you have to compress against the head of the femur. If it dislocates, you cannot feel. Similarly, in the child, in congenital dislocation of hip, you will not be able to feel the femoral artery pulsation in very similar to posterior dislocation of hip as an adult. That sign is called as vascular sign of Narad. So that is called as vascular sign of Narad. So where the femoral pulsations are not palpable because of dislocation. not valuable because of dystrophy. Okay. So these are two important conditions. That if there is an X-ray, I'll just show you an X-ray. Yes. Can you able to see the picture here? What is this line called as yellow color line? It is Klein's line. Here it is cutting the head, but on this side it is just touching or it is not cutting through it. So this sign is called as what? Trithovan sign. This sign is called as Trithovan sign. And how do you fix it? You fix it with a screw like this. You fix it with a screw like this. You can do prophylactic pinning. Both the sides you can do. Okay. Okay, so now we'll move to the next part of pediatric orthopedics. So we'll be starting about this condition called as Perthes disease. Perthes disease is also called as Leckalvi-Perthes disease. Leckalvi-Perthes disease. This is very similar to avascular necrosis of femoral head. So this is nothing but avascular necrosis of femoral head. Nothing but avascular necrosis of femoral head. Okay. So you all know that the head of the femur receives lot of blood supply via retinacular vessels, via artery to ligament of femur, and through metaphyseal vessels. Now, when the blood supply to the head is lost, we call that as avascular necrosis. When the blood supply is lost, so these are retinacular vessels. These are retinacular vessels. These are metaphyseal vessels. And this is artery of ligament of femur. Artery of ligament of femur. So when the blood supply to the head is cut off, then it results in avascular necrosis of femoral head. Okay, results in avascular necrosis of femoral head. And this condition can occur because of trauma. Because of trauma, the blood supply can get cut off, or it can occur in conditions like sickle cell disease. It can occur in conditions like sickle cell disease. It can occur in conditions like Gaucher's disease. It can occur in conditions like Gaucher's disease. It can occur in other conditions of hemoglobinopathies. Hemoglobinopathies. It can occur in conditions like protein C or protein S deficiency. Protein C or protein S deficiency. So there are various causes for Perthes disease. So what you have to understand from Perthes disease is it is because of loss of blood supply to the femoral head. Okay. So very similar conditions can occur in other parts of the bone. So similar conditions can occur in other parts of the bone. So such a condition happening in navicular bone. Such a condition happening in navicular bone is called as Kohler's disease. It's called as Kohler's disease. Very similar to Perthes disease. A similar condition, that is loss of blood supply. If it happens in navicular bone, we call that disease as Kohler's disease. If the same happens in lunate bone, we call that as Kienbock's disease. We call that as Kienbock's disease. If the same happens to second metatarsal head, we call this as Freiberg's disease. All are similar to Perthes disease. That is, blood supply to the bone is affected. We give specific names for such a condition. So in Kohler's disease, navicular bone is affected. In Kienbock's disease, lunate is affected. In Freiberg's disease, second metatarsal head is affected. In Panner's disease, capitulum is affected. In Panner's disease, capitulum is affected. These are few examples where you get a similar condition like Perthes disease. Okay. Now, whenever a blood supply is lost to the femoral head, what are the signs the patient will present with? The patient will present with pain, and patient will present with difficulty in bearing weight. Patient will have difficulty in bearing weight. And when you examine the patient, he will have loss of internal rotation movement. He will have loss of internal rotation. The hip internal rotation gets affected when the patient suffers from Perthes disease. When the person suffers from Perthes disease, there will be loss of internal rotation or restriction of internal rotation. So when the blood supply is lost, what are the futures that can happen? Usually the bone dies and it becomes sclerosed. Below the sclerosed area, there can be occurrence of subchondral fractures, which we call as crescent sign. The fractured fragment can further goes in for fragmentation. If the blood supply is retained, if it is provided at the right time, it can heal. If it is not, it goes in for arthritis. If blood supply is reversed, if blood supply is provided at the right time, then there is a chance for it to heal. If the blood supply is not provided, lack of blood supply destroys the cartilage and it results in arthritis of the joint. There are various classifications to diagnose Perthes disease. So few classification names. One is Steenberg's classification. There is a classification called the Steenberg's classification. There is a classification called as Herring's lateral pillar classification. There is a condition called as Herring's lateral pillar classification. So these classifications are used to classify the Perthes disease. Can be used to classify Perthes disease. If you see these pictures, you can see various things in this. You can see the bone is getting dense in this region. Can you able to see the bone is getting dense compared to the other part? So that is the sclerotic part. After sclerosis, the fracture happens and fragmentation happens. Fragmentation and subchondral fracture happens. Subchondral fractures happen and fragmentation happens. Okay, now can you able to see the fragmentation clearly? If it is treated properly, it heals. If it is treated properly, it heals. If it is not treated properly, you will land up in arthritis. Now, this is one classification where you can use to treat or diagnose Perthes disease. So this is called a Herring's classification. I don't want the details of this. It is not necessary for you. You just understand that there is a classification called as Herring's lateral pillar classification. They won't ask you much in that. Why this is called as Herring's lateral pillar classification? Because in Perthes disease, anterolateral part of the head is commonly involved. Once if you diagnose a patient with Perthes disease, you have to keep him on non-weight bearing. The child should not weight bear on that side. Non-weight bearing is important for treatment. And how can you keep the child in non-weight bearing? One, you can put a cast like this. This cast is called as broomstick cast. Where the hip is kept in abduction, and internal rotation. Very, very important. Okay, so if you keep the child with abduction and internal rotation, the head stays within the joint and there is more chances for the head to recover. Otherwise, the head will subluxate. If the child is not treated at the right time, if there is deformity happening in the head, then he might require varus derotation osteotomy. He might require varus derotation osteotomy, or he can land up in pelvic osteotomy. Pelvic osteotomy to contain the head. To contain the head. So these are the various treatment modalities for Perthes disease. Various treatment modalities for Perthes disease.